you finish lunch. The plate is cleared, and within 30 minutes something happens. A heaviness settles behind your eyes. Your concentration dissolves. If you are at home, you are on the couch. If you are at work, you are fighting to stay present. And underneath the sleepiness, there is sometimes a restlessness, a slight shakiness, a craving for something sweet that arrives before you have even fully digested what you just ate. You have probably called this a food coma. Most people do. So, most people consider it unremarkable. They eat, they feel this way, it passes, and by dinner the cycle begins again. And somewhere in the familiarity of it, in the fact that it happens to most people they know, it becomes invisible. It becomes just what eating feels like. Here is what I want you to consider this morning. That pattern, the crash, the fog, the shakiness, the craving that reappears 90 minutes after a meal, is not a harmless quirk of digestion. It is a metabolic event. And in adults over 60, it is one of the most consistent early signals of a blood sugar regulatory system that is losing its precision. A system that, if the signal is not read and the pattern is not addressed, will move toward prediabetes and then toward type 2 diabetes, over a timeline measured not in months, but in years. The frustrating truth is that this progression is often invisible to standard medical monitoring. An annual fasting glucose check that comes back at 104 is noted and filed. The patient is told to watch their diet. No one explains what that number actually means, or what is happening inside the body in the hours after every meal, or why the tiredness after lunch that has been building for 3 years is directly connected to where that number is heading. That connection is what this video is about. Before anything else, what I share here is educational information only. It is not medical advice. If you are experiencing significant symptoms after eating, particularly chest discomfort, a racing heart, sweating, or sudden severe weakness, please speak with your healthcare provider promptly. Some of the symptoms I am going to describe exist on a spectrum, and the severe end of that spectrum warrants clinical evaluation rather than self-management. What I want to give you today is the framework to understand what is happening in your body after meals and the specific questions to bring to your next appointment. I am Dr. Andrew Carter, 15 years working exclusively with adults over 60. And the reason this video matters to me is that I have sat with people who were told their blood sugar was fine, who had been experiencing post-meal fatigue and cravings for years, and who were eventually diagnosed with type 2 diabetes that had been developing and producing symptoms the entire time. The gap between the symptom and the understanding was years, and in those years, the metabolic damage was accumulating in silence. If this is your first time on this channel, subscribe right now. Every week I bring you specific, grounded information about what your body is communicating after 60. The information in this video may be the most metabolically important thing you watch this year. Let me start with what actually happens in the body in the 2 hours after a meal, because most people have a vague understanding of blood sugar, but not a precise one. And precision here changes everything. When you eat a meal containing carbohydrates, those carbohydrates are broken down in the digestive tract into glucose, the primary fuel the body uses. That glucose enters the bloodstream through the walls of the small intestine. Blood glucose rises. The pancreas detects the rise and responds by releasing insulin, the hormone that acts as the key that unlocks cells and allows them to take up glucose from the blood. Muscle cells, fat cells, and liver cells open their doors to glucose under insulin's instruction. Blood glucose falls back toward baseline. The system returns to equilibrium. In a healthy metabolic system, this entire sequence happens with elegant precision. The insulin response matches the glucose load. The cells respond efficiently to insulin signaling. Blood sugar peaks modestly, falls smoothly, and returns to a stable baseline within about 2 hours. The person feels satisfied after the meal, energetic, ready to continue the day. In a metabolic system where insulin resistance has begun to develop, this sequence runs differently. Insulin resistance means that the cells have become less responsive to insulin signal. The key fits the lock, but the lock is stiff. More insulin is required to produce the same effect. The pancreas compensates by releasing more insulin, and more still, and in the early stages, it succeeds. It releases enough extra insulin to drive glucose into the cells and bring blood sugar back toward baseline. The fasting glucose looks normal. The person is not diabetic by clinical criteria, but the process of driving blood glucose down with the extra insulin is not smooth. It can overshoot. The blood sugar that was elevated from the meal comes down past the ideal baseline, dropping into the low normal or even low range. And in that drop, The body perceives a threat. Adrenaline is released. The liver is triggered to release stored glucose. The brain, which runs entirely on glucose and has no storage reserve, signals urgency. And the person experiences the cluster of symptoms that follows a postprandial glucose crash: fatigue, cognitive fog, irritability, shakiness, anxiety, heart palpitations, and an overwhelming craving for carbohydrates to bring the blood sugar back up quickly. That craving, when answered with another sugary or refined carbohydrate snack, starts the cycle again. Another glucose spike, another overshooting insulin response, another crash, and another craving. 3 times a day this cycle runs, wearing down the pancreatic capacity to produce compensatory insulin, deepening the insulin resistance in the cells, and moving the metabolic picture progressively toward a diagnosis that nobody warned the person was coming. A study published in the journal Cell Metabolism found that large postprandial glucose spikes, even in adults with normal fasting blood glucose, were independently associated with higher rates of metabolic disease progression, higher rates of cardiovascular events, and higher inflammatory marker levels over a 5-year follow-up. Do not see normal fasting glucose still at risk. Because fasting glucose is only one snapshot of a system that runs for 24 hours a day, and it misses the hours after meals entirely. The first symptom to understand is the one that most people accept as inevitable: post-meal fatigue. The crash that follows a carbohydrate-heavy meal, particularly a meal high in refined carbohydrates or sugar, and that produces a level of tiredness disproportionate to what eating should cause. The mechanism is the glucose crash I described. But there is a second layer that is worth understanding. When blood sugar drops following an insulin overshoot, tryptophan, an amino acid from the meal, crosses the blood-brain barrier more efficiently. Tryptophan is the precursor to serotonin, and serotonin is the precursor to melatonin. The cascade is post-meal glucose drop, increased tryptophan uptake by the brain, increased serotonin synthesis, downstream melatonin production, sleepiness. This is why the carbohydrate-heavy lunch is more reliably sleep-inducing than a protein-heavy one. The mechanism is not the food sitting heavily in the stomach. It is a neurochemical response to the glucose and insulin dynamic that follows it. In an adult with normal insulin sensitivity, the glucose excursion after a meal is modest. The insulin response is matched. The crash is minor. The tryptophan effect is minimal. The person feels satisfied and alert. In an adult with developing insulin resistance, the glucose excursion is larger, the insulin overshoot more pronounced, the drop steeper, and the neurochemical cascade more significant. The tiredness is not mild. It is the kind that makes continuing work feel almost impossible. It is the kind that becomes a predictable 30-minute window of barely functional existence after every lunch. If you recognize this pattern, the question worth asking is not how to push through the fatigue. The question is what the meal composition was that preceded it. Specifically, what proportion of the meal was refined carbohydrate? White bread, white rice, pasta, potatoes, sweetened sauces, fruit juice, and how little protein, fat, and fiber accompanied that carbohydrate. Because protein, fat, and fiber all slow the gastric emptying that determines how fast glucose enters the bloodstream. A meal that is mostly refined carbohydrate with minimal protein, fat, or fiber produces the fastest and largest glucose spike. The one that leads to the largest insulin overshoot. The one that causes the deepest crash. This is not about eliminating carbohydrates. It is about understanding that the composition and the sequence of a meal determines the metabolic event that follows it. Type in the comments right now how long after your meals the fatigue typically arrives. Not 30 minutes, 45, and how long it lasts. Because the timing and duration of post-meal fatigue is clinical information, and the patterns in those comments will tell me a great deal about what is happening metabolically in the people watching this video. The second symptom is one that is more alarming in its presentation, but is often dismissed once it passes. A racing heart, palpitations, or a sense of anxiety that appears in the hour or two after eating, without an obvious emotional trigger. When blood sugar drops after a meal, the adrenal glands release adrenaline. This is a counter-regulatory response. The body interprets the dropping glucose as a threat and activates the sympathetic nervous system to mobilize stored glucose quickly. Adrenaline does this effectively. It also produces every other effect of adrenaline release: a faster heart rate, a pounding or fluttering heart sensation, heightened alertness that presents as anxiety, sweating, and a feeling of unease that is indistinguishable from a panic response. Many adults who experience this describe it as anxiety, or as their heart behaving strangely after meals, and attribute it to stress or to the psychological response to eating. They do not connect it to blood sugar. Their doctor does not connect it to blood sugar. And it continues, sometimes for years, as an unexplained post-meal experience. The distinguishing feature is its timing and its relationship to what was eaten. If palpitations or anxiety-like symptoms appear consistently in the hour to 90 minutes after a carbohydrate-heavy meal, and if they resolve on their own within 30 to 60 minutes, and if eating a small amount of protein or complex carbohydrate at that moment makes them resolve more quickly, the mechanism is almost certainly adrenaline-mediated counter-regulation in response to a glucose drop. That mechanism is a reflection of insulin resistance. I want to be direct about something important here. Post-meal palpitations that are accompanied by chest pain, that are severe, that do not resolve within an hour, or that are associated with sweating and shortness of breath, need to be evaluated by a doctor today. Not because the blood sugar connection is unlikely, but because palpitations have a differential diagnosis that includes cardiac causes, and those need to be excluded before the metabolic picture is the only explanation in the room. What I am describing is a specific pattern, mild, consistent, timing-related, resolving. If that is your experience, the blood sugar picture warrants investigation. If your experience is more severe or unpredictable, please have it evaluated clinically before managing it independently. The third symptom is one that most adults over 60 experience regularly, and have been told is simply part of a busy life or the demands of aging. Cognitive fog and difficulty concentrating that arrives after meals and is distinct from ordinary tiredness. The brain is the most glucose-dependent organ in the body. It uses approximately 20% of the body's glucose supply, despite representing only about 2% of body weight. It has no meaningful glucose storage of its own. It depends on a stable circulating blood glucose level to maintain the functions of cognition, attention, memory retrieval, and language processing. When blood sugar drops after a meal in the pattern of an insulin overshoot, the brain is among the first tissues to register the reduced supply. Not because the blood sugar falls to a dangerous level, but because the brain is exquisitely sensitive to the rate of change, rather than simply the absolute level. A blood sugar falling quickly from 140 to 85 milligrams per deciliter feels very different to the brain than a stable 85. The rapid fall signals scarcity, and the brain responds by pulling resources away from complex cognitive tasks toward the basic functions of attention to survival. Thinking becomes slower. Words become harder to retrieve. Decisions feel effortful. Concentration requires an act of will rather than being automatic. Many adults in their 60s and 70s who have been experiencing this for years have attributed it to age-related cognitive change. They have accepted the diminished afternoon mental capacity as the new normal. They have scheduled important tasks for mornings when cognition is strongest and avoided demanding cognitive work in the afternoon when the fog predictably arrives. But when the fog is post-meal rather than general, when it follows a specific pattern of appearing 30 to 90 minutes after eating and clearing within 2 hours, it is metabolic in origin rather than degenerative. The brain is responding to a blood sugar event, not to neurological change. And addressing the blood sugar event with the specific dietary and lifestyle changes I am going to describe can restore that afternoon cognitive function in a way that no amount of accepting age as the explanation will. A study published in the journal Nutritional Neuroscience found that postprandial glycemic variability, the degree of blood sugar rise and fall after meals, was significantly associated with cognitive performance in the hours following those meals in adults over 60. Higher spikes and deeper crashes produced measurably worse cognitive performance on attention and processing speed tests. The relationship was dose-dependent. Greater glycemic variability, greater cognitive impairment in the postprandial window. This is not a minor academic finding. This is a mechanism by which what you eat for lunch is affecting how well you think for the 2 hours that follow. And if you have not yet subscribed to this channel, tap that button right now and ring the bell. Every week I come here with exactly this level of specific, research-grounded information, because the connection between what you eat and how your brain performs in the hours after is something most people have never had explained to them this clearly. I want to tell you about Patricia, 68 years old, retired accountant from Cincinnati, Ohio. She came to me because she had noticed that her mental sharpness had declined over the past 3 years in a way that frightened her. She had always been precise, detail-oriented, reliable with numbers, and she was finding that by early afternoon she was making small errors that she would not have made before, losing her train of thought mid-sentence, searching for words that should have come easily. She had spoken to her doctor about it. A cognitive screening test had been administered. It had come back within normal range. She had been told that some cognitive changes were expected with age, and that she should keep mentally active and get adequate sleep. When I spoke with Patricia, I asked her to describe her lunch. Every day, reliably, a sandwich on white bread, a handful of pretzels, and a glass of orange juice. Sometimes a cookie. A meal that was almost entirely refined carbohydrate, with almost no protein, fat, or fiber to moderate the glucose response. And her afternoon cognitive symptoms began approximately 45 minutes after that lunch. Every day, her fasting glucose was 108. Her HbA1c was 5.9%, pre-diabetic range, on the edge of the pre-diabetic threshold, moving in a direction that had been consistent for at least 2 years based on her previous labs. We made one change to begin with. We changed the lunch. Salad or vegetables, then complex carbohydrate if desired. No fruit juice. No processed snack foods. 3 weeks later, Patricia told me the afternoon fog had not arrived. Not one afternoon in 3 weeks. She said, "I thought I was losing my mind. I was just losing my lunch." The fourth symptom brings together the pattern I have been describing and places it in the context of the long-term risk that makes the entire picture urgent rather than merely interesting. The cycle of craving, eating, spiking, crashing, craving again, is not simply uncomfortable. It is biologically corrosive over time, and the 4 specific downstream consequences are worth understanding clearly. The first is the progressive deepening of insulin resistance itself. Every time the pancreas is required to release a large bolus of insulin to compensate for a rapid glucose spike, the cells of the body are exposed to high insulin levels. Over time, in a process called downregulation, the insulin receptors on the cell surface reduce in number and sensitivity. The cells are protecting themselves from chronic insulin overstimulation by becoming less responsive, and the result is that the same glucose load now requires even more insulin to manage. The resistance deepens. The compensation requires more effort. The pancreas, which has been working overtime for years, begins to lose capacity. The fasting glucose climbs. The HbA1c climbs. The prediabetes that was borderline becomes established. The diabetes that was preventable becomes present. The second downstream consequence is chronic inflammation. Rapid glucose spikes activate inflammatory signaling in the endothelial lining of blood vessels, in the same arterial tissue we discussed in previous videos. Advanced glycation end products, compounds formed when glucose binds to proteins in the vessel wall, accumulate. The arterial lining stiffens and becomes more permeable to LDL cholesterol. The atherosclerotic process accelerates, and the cardiovascular risk that is already elevated in an adult over 60 is amplified by every postprandial glucose event that exceeds the normal range. The third consequence is weight accumulation, specifically in the abdominal region. When insulin levels are chronically elevated, the body is in a fat storage state. Insulin is the primary anabolic hormone. It drives nutrients into storage. It suppresses fat burning. In a person cycling through repeated glucose spikes and high insulin responses, the metabolic environment is one that favors fat deposition, particularly visceral fat, around the organs. And visceral fat is itself metabolically active, releasing inflammatory cytokines that further drive insulin resistance. The cycle reinforces itself. The fourth consequence is the direct impact on pancreatic beta cell function. The beta cells of the pancreas are the cells that produce insulin. They are sensitive to the oxidative stress that accompanies chronic high glucose exposure. Over years of overwork and chronic glycation stress, beta cell function declines. The pancreas eventually loses the capacity to produce adequate insulin in response to glucose loads. This is the transition from insulin resistance with compensatory hyperinsulinemia to frank diabetes, where the compensatory mechanism itself fails. All 4 of these processes are operating in the background, invisibly, in a person who is experiencing post-meal fatigue and cravings and assuming it is a normal part of life. A study published in the American Journal of Clinical Nutrition found that adults with the largest postprandial glucose excursions, even when their fasting glucose was technically in the normal range, had significantly higher rates of cardiovascular events, significantly higher inflammatory markers, and significantly faster progression to type 2 diabetes over a 10-year follow-up than adults with modest postprandial excursions. The difference was not in the fasting glucose. It was in what happened after meals, in the hours that standard blood glucose monitoring almost never captures. Here is what you can do, specifically and practically, starting with your next meal. The first and most impactful change is meal composition and sequence. Before any refined carbohydrate enters your digestive system, eat protein and fiber. This can be as simple as eating the salad or vegetables before the bread, eating the protein component of the meal before the carbohydrate portion, beginning lunch with a handful of almonds before eating the sandwich. The fiber and protein slow gastric emptying. Glucose enters the bloodstream more gradually. The insulin response is proportional rather than compensatory. The crash is smaller. The symptoms are reduced. A study published in Diabetes Care found that eating vegetables before carbohydrates at each meal reduced postprandial blood glucose by approximately 37% in adults with metabolic conditions. 37%. From the sequence of the same foods, not the elimination of any food, just a change in the order they are eaten. The second change is the reduction of liquid calories and liquid glucose at meals. Fruit juice, sweetened beverages, and alcohol all deliver glucose into the bloodstream faster than solid food, because the absence of fiber and solid matrix means digestion is minimal and absorption is nearly immediate. Replacing orange juice with whole fruit and replacing sweetened drinks with water or an unsweetened tea removes some of the fastest and largest glucose inputs from the daily pattern. The third change is a 10 to 15-minute walk after the main meal of the day. Muscle contraction during exercise activates a glucose transporter called GLUT4 through an insulin-independent pathway, meaning glucose enters the muscle cell without requiring insulin to unlock the door. The postprandial glucose that would otherwise remain in circulation and provoke a large insulin response is partially cleared by the working muscle directly. Studies have consistently shown that a short walk after eating reduces the postprandial glucose peak by 20 to 30%. Not a long walk. 10 to 15 minutes is enough to produce a meaningful effect. The fourth change is the most important conversation you can have with your doctor. Ask for an HbA1c, which reflects your average blood glucose over the preceding 3 months, in addition to the fasting glucose that is typically measured. If your fasting glucose is 104, your HbA1c may be 5.7 or 5.8, and that number in context with the post-meal symptoms I have described tells a very different story than the fasting glucose alone. Ask also whether a 2-hour postprandial glucose test, measuring blood glucose 2 hours after eating a standardized glucose load, is warranted. This test directly captures the postprandial excursion that is producing your symptoms, and that fasting tests miss entirely. If you are in the pre-diabetic range, meaning fasting glucose between 100 and 125, or HbA1c between 5.7 and 6.4, this is the window in which the trajectory can be changed. Not managed, changed. The research on lifestyle intervention in prediabetes is among the most robust in preventive medicine. A landmark study called the Diabetes Prevention Program found that adults with prediabetes who made specific lifestyle changes, including modest weight reduction, dietary modification, and 150 minutes of moderate exercise per week, reduced their risk of progressing to type 2 diabetes by 58%. 58%. The medication arm of the same study produced a 31% reduction. Lifestyle was nearly twice as effective as medication, and the window in which lifestyle produces those outcomes is exactly the pre-diabetic stage, before the beta cell capacity is lost. Type yes in the comments right now if you have post-meal fatigue, cravings, or brain fog that you have been accepting as normal, and have never had your postprandial glucose pattern specifically evaluated. Because if the answer is yes, you are the person this video was made for. And share it right now with one person in your life who complains about always being tired after lunch and has been told it is just their schedule. You may be handing them a metabolic conversation they should have been having years ago. Let me give you the complete picture one more time, so that the next time you eat a meal and feel the familiar wave of tiredness arrive at the 30-minute mark, you have a framework for understanding what is happening rather than simply experiencing it. Carbohydrate enters the digestive system. Glucose rises in the blood. In a system where insulin resistance has begun to develop, the pancreas overshoots with insulin to compensate. Blood glucose drops below baseline. The adrenal glands respond with adrenaline. The brain registers the glucose fall as a threat. Yes, that's your cognitive function degrades. Adrenaline produces palpitations and anxiety. The neurochemical cascade produces sleepiness. And the low blood sugar signals an urgent need for more carbohydrate, which when consumed restarts the entire sequence. That cycle is not a food coma. It is a metabolic distress signal running 3 times a day, telling you that the system designed to manage blood glucose is losing its ability to do so smoothly. The meal sequence change addresses it at the source by slowing glucose entry and reducing the spike that triggers the compensatory response. The post-meal walk addresses it by clearing glucose through an insulin-independent pathway. The dietary modification, reducing refined carbohydrate and liquid sugar in favor of protein, fat, and fiber, reduces the glucose load that initiates the cycle. And the medical conversation, requesting HbA1c and a postprandial glucose assessment, puts numbers to a process that has been operating for years without a label. You are not simply tired after meals because you are getting older. Your metabolism is not simply slowing down in a vague and unspecific way. Something specific is happening. It has a name, it has a mechanism, it has a test, and it has an intervention window that right now is still open. Do not wait for a diagnosis to take this seriously. The diagnosis is often the signal that the window has narrowed. The symptoms are the signal that the window is still wide, and that the changes you make now will produce outcomes that the changes made after a diagnosis simply cannot. Share this video with someone who experiences the afternoon crash every single day and has never connected it to their blood sugar. And subscribe to this channel because every week I come here with one purpose: to give you the information your body has already been trying to communicate in language clear enough to finally act on. Aging does not take away your body's ability to recover. It simply reminds you to care for it the right way. Take care of yourself.